All right, so this is on the thoracic spine. I just realized in the end of the cervical one, I forgot to include a few cases of cervical ribs, so I just want to show you those. And how do you know they're cervical ribs? Well, first of all, they're these tiny little ribs, but the other thing is sometimes they're more well-formed, is that T1's transverse processes should point up like this, and C7 should point horizontal to down, and these are coming off of that. So that's cervical ribs. Just another case. This one's quite a bit more well-formed, almost looks like a first rib. And then we've got a little riblet over here on the other side. Okay, and so again, these are horizontal. T1's transverse processes are pointing up. All right, so here's some of the more common spine and chest cases you might encounter. So you can review this slide if you want to know a list of cases to go look up. And just to show you a few cases here of the things I mentioned in the previous slide. This case is of dish, of course. Again, we have our very, very hyperplastic kind of calcification of the anterior longitudinal ligament kind of plastered along the right side of the vertebral bodies. It's not on the left because we have our aorta over here, which pulsates constantly, and that inhibits formation of calcification within the ALL on that side. And this person also has a little calcification in the wall of the aortic arch called thumbnail calcification. And extensive costochondral calcification, no one cares about that. So this is a case of dish. Here's another example of a case of dish. On the frontal view, this is what it looks like. Not quite as impressive as we saw on the cervical spine. Bit more impressive on the right-hand side, and again, none on the left. So this is a classic dish where it doesn't form here and then forms quite a bit on the right-hand side. Here's another example where it's a little bit more impressive on the lateral view. Kind of looks like more hypertrophic flowing hyperostosis. Looks like someone came and plastered on some calcium. And so this was a bit more like the cervical spine cases we saw previously. All right, so let's go on to this next case. I apologize if there's noise in the background. Our street sweeper has gone past my apartment for the 13th time in the last hour. So on this case, this isn't dish. So in the last case, you saw what it would look like. Sometimes it's not quite this impressive like we saw in the prior case, but in this one, this is marginal syndesmal phyte formation. So this patient has AS, and you can see it, it's kind of hard to tell posteriorly. Up here, this one's definitely bridged. But in the normal lateral thoracic spine, if we just look at this one, there are these little bumps, and so it is sometimes hard to tell posteriorly if it's fused, because you could argue that one looks fused, but that's just normal. But in this case, they do have posterior fusion, marginal syndesmal phyte formation anteriorly, especially down here. So this is a case of AS. Here's a case of thoracic spine compression fracture, and so this can be a bit subtle, so I've highlighted here the anterior vertebral body heights. You can see that this one's normal, and this one's normal, and this one is decreased by maybe 40%. So make sure you're going through in the thoracic spine and you're looking to see if there's any wedge vertebra, and don't necessarily look for the wedge. Look at the anterior vertebral body heights and see if there's one that stands out. So if we scan down here, we'd notice that this one's less, and then keep going, even though when we just glance at the vertebral body morphology itself, it may not be quite as obvious. Here's an example of someone with emphysema, and you can see they've got flattened depressed hemidiaphragms, they've got a barrel chest deformity, kind of hypertranslucent lungs, and so that's one thing. Okay, so they have emphysema, and the main reason we can tell that is these flattened depressed hemidiaphragms. They should be more like this. Chest should be more like wedge shaped. And then we look at their spine, and we follow this down. Okay, they have some degenerative osteophytes, no big deal. But then we get to this level, right? Look at that anterior vertebral body height, very diminished. Okay, so they have a wedge fracture here, and I think this person actually ended up having multiple myeloma. So these people probably should get an MRI for further assessment when you have a compression fracture to see A, if it's acute, B, if it involves the central canal, and C, if there's some underlying lesion predisposing the person to these compression fractures. So here's another example. This person, again, had multiple myeloma, if I remember. And we look through here. These all look pretty normal. We get to this one, decreased vertebral body height, wedge deformity. So this is a compression fracture. They got a limbus bone down here as well. Here's an example of someone with a mediastinal mass, and so you can see that we should see our aortic arch. We should maybe see a little bump for the left atrium, left ventricle. This is all extra. Okay, our hyla comes out here. We can maybe see some vessels, but this is a mass. Okay, so this person has a bronchogenic carcinoma, most likely. Could be lymphoma, could be a number of other things, but nothing good is going to show up as a hilar mass in most instances. Here's another one, hilar mass here. Okay, so we should see superior vena cava come down, right atrium, right ventricle mainly. and maybe see some hilar vessels coming out here, but this is a kind of more of a focal mass lesion. We shouldn't see a well-defined edge out here laterally. I believe this wasn't a neoplasm, but the first differential should be a bronchogenic carcinoma or lung cancer. All right, in this case, we see a left hilar mass. It's a little bit more prominent. It should look more like the right hilum. So this person has a hilar mass, has a little bit of some peripheral changes here. This is just a calcified, probably an old calcified granuloma from old infection. No big deal. They have some osteophytes here on the right-hand side. It's not really dish. We can look here and can see claw osteophytes, and they kind of form on the right more so than the left, just like dish does for the same reason, because of the inhibitory pulsations of the aorta. The aorta is a little tortuous here. We see that with advancing age. The aorta becomes weak just like their skin does, and it can become a little bit tortuous. No big deal. Here's an example of someone with pneumonia, and so you can see that they've got kind of these diffuse kind of opacifications in the lungs, indicating kind of infiltrative changes. We call this consolidation. So we kind of have air replacement with water. That's consolidation. So this indicates pneumonia, most likely. All right, here's a kind of diffuse consolidative area on the right mid-lung zone, and you can see it's pretty normal hyla here in this case to compare with the prior cases. So here's an example of someone with a pneumothorax. And so pneumothorax is when you get air outside your lung. So either you have some kind of maybe little tear, microscopically. But in any case, this is a really, really obvious case, because we can see we should have normal kind of arborization of lung vessels out here. And in this case, that stops. So this is actually the edge of the lung. This is the visceral pleura. We'd expect to see vessels here. We don't see vessels. This is pneumothorax. And so you might think that this isn't going to walk in your office and this is not going to show up on boards, but this is a case that a chiro took because a guy had 10 days of upper back pain and he was stretching, not getting better. You can see he's got some hyperplastic transverse processes here. And we look at our lung apex like we talked about with our Pancoast tumor, and this one looks pretty normal. You see some arborization, lung stuff up here, but this one's empty, right? So this person's lung, their entire right lung is here. And you can see that lateral displacement of the heart pushing it away. So this person has a massive pneumothorax, right? This whole thoracic cavity is empty. Okay, so this happens sometimes, and it causes back pain. Young, healthy men more commonly, and so this is a case of pneumothorax. This is very obvious. So this is as obvious as it gets. No one should miss this. Okay, I wouldn't even put this on board. It's too easy. What's more common is a situation where we have a chest radiograph and we see this kind of edge here, right? Which crossing the ribs. It's not going along with the ribs. This is the visceral pleura. And there's free air up here, right? So here's this crescent of free air. So this is something you specifically want to look for. So you look at the apices, okay, no mass. But you look at them again, okay, you see some thin little vessels coming up here. There's some density here. There's lung tissue. No lung tissue right here. This is free air outside the lung. Here's a case. We look at this one. Okay, we have some degenerative osteophytes kind of going throughout the thoracic spine. No big deal. These all look wedged though, don't they? Every one looks wedged, essentially. Are these all compression fractures? No, it's a young, healthy guy. He has weak end plates, and so this is Schurman's disease. You got some Schmorl's nodes in here. You got some kind of wavy, irregular end plates. This is what Schurman's disease looks like. Here's an example of someone, he comes with arrows. Boards doesn't come with arrows, but they've got this big mass thing here. It's outlining. This is a hiatal hernia. Hiatal hernias often present with a retrocardiac mass, and you'd like to see some kind of gastric air bubble in it. The gastric air bubble is usually here and then goes up into this. This case, maybe there's a little one here, but you don't see necessarily that, obviously. But when you see a midline mass like this overlying the heart shadow, you should think hiatal hernia. Here, this one's a bit more obvious. All right, so you can see this kind of pumpkin growing here. Got gastric air bubbles up there. So this is their Magenblasen, and this is a hiatal hernia. All right, so this is another example where we can see a Pancoast tumor, right? We look at the lung apice, there's a lesion here. Maybe not necessarily Pancoast tumor. I think this was a MET, and then you can see there's other metastatic lesion here. And you see that this one is, again, invaded and destroyed the phrenic nerve, so they've got a big phrenic nerve palsy with elevation of the hemidiaphragm, right? They're unable to contract it because this thing has destroyed their phrenic nerve. This one's normal down here. Here's an example of someone with a subpulmonic effusion. right? There's a huge differential for that. It could be infection or heart failure, any number of things. But this is fluid filling up underneath the lung, right? This is our meniscus sign, okay? So this is a subpulmonic effusion or pleural effusion, fluid filling the potential space between the pleura. This is something that definitely needs follow-up chest CT and medical referral. Here's an example of an extrapleural sign. So this is in a subpulmonic effusion. We don't see any meniscus sign. These look normal. What we do see, though, is this thing, right? And it's got oblique intersections with the chest wall, meaning it's pushing in the lung, right? It's not adjacent. It's not like a lesion right here, which would have an acute angle, right? This is an acute angle, right? This has an oblique angle, meaning it's pushing in. So there's some type of rib lesion. Could it be a rib fracture? It's possible. Could it be a rib met? Yeah, definitely. So often that's the case where they have a metastatic rib lesion and it shows up an extrapleural sign. Here's an example of someone, we're looking at this here. So let's go through a search pattern, right? Lung apices, okay, those look normal. Hyla, yeah, you could maybe be suspicious of that one. That's normal. It's a big pulmonary artery. But this is pretty normal. Heart shadow is normal. Aorta, minimally tortuous, but it looks pretty normal. Chest wall looks fine. We go through each rib quickly. Those all look good. Extrathoracic tissues, those are fine. There's no hiatal hernia. Lung fields are clear. And then we look at the abdomen, right? Now we get to the abdomen. Hemidiaphragm's nice and smooth. They're where you expect to find them, but right, we should have liver right up against our hemidiaphragm. There shouldn't be gas here. This person has free air in their peritoneum because they have some type of bowel perforation or something like that. So this is what pneumoperitoneum looks like, free air, kind of outlining the undersurface of the hemidiaphragm. Usually the liver would go right up there and you wouldn't see that. We expect to see air here because of our gastric air bubble, of course, but this is free air above it, right? We can outline the diaphragm. This is probably their Magenblas here or something. All right, so that's the quick overview of the thoracic spine and chest stuff that you might encounter on boards. Hopefully that's helpful. I'm just scanning through some cases. I don't know why. So I want to stop this video and start a new one for the lumbar.